Perimetry is a psychophysical test used to evaluate the visual field. It plays a crucial role in diagnosing and monitoring glaucoma, optic nerve disorders, and retrochiasmal lesions. Perimetry is not optional. It detects functional loss before structural damage, especially in glaucoma and compressive optic neuropathies. If you can't interpret a field, you don't understand the disease. Visual field is the area seen by a fixating eye. The visual field is a three-dimensional hill. Sensitivity peaks at the fovea and slopes down peripherally. This concept explains everything that follows. The visual field extends 50 degrees superiorly, 60 degrees nasally, 70 degrees inferiorly, and 90 degrees temporally. The blind spot corresponds to the optic disc, temporal and slightly inferior. An isopter is a line joining points of equal retinal sensitivity and is a fundamental concept in kinetic perimetry. When the field is represented as a hill, isopters resemble the contour lines on a map. Scotomas may be relative or absolute. An area of reduced vision surrounded by a seeing area indicates relative scotoma, and an area of total loss of vision surrounded by a seeing area indicates absolute scotoma. Luminance is the intensity or brightness of a light stimulus. It is measured in apostiles. Sensitivity is inversely related to luminance. The eye responds logarithmically, not linearly. That's why perimetry uses log units. It magnifies early defects that would otherwise be missed. Do not confuse decibels with true luminance. They are relative units. A higher number means better sensitivity, not brighter light. 10 decibels is equal to 1 log unit. Higher decibels means higher sensitivity. Blind spot has 0 decibels. Values differ between machines. Sensitivity declines after age 20, approximately 1 decibel per decade. This is why age-matched normative databases are mandatory. Otherwise, you will overdiagnose glaucoma. Perimetry is based on differential light sensitivity, which is the ability of the retina to detect differences in luminance. Threshold is defined as the minimum stimulus intensity detected 50% of the time at a given retinal location. A constant background luminance is used to prevent dark adaptation and maintain standard testing conditions. Perimetry can be classified based on whether the testing is manual or automated and whether the stimulus is moving or stationary. Goldman perimeter is an example of manual perimetry. It is examiner dependent. It is useful in poor cooperative patients and in advanced disease. It is now largely replaced by automation. Automated perimetry provides standardized and quantitative assessment of visual fields. Humphrey's field analyzer dominates clinical field. Automated perimetry allows comparison with normative databases and longitudinal monitoring. Static perimetry determines threshold sensitivity at fixed retinal locations by varying stimulus intensity, whereas in kinetic perimetry, A stimulus of constant intensity is moved from a non-seeing area into a seeing area to plot isopters. Different testing strategies or algorithms are used depending on whether precise threshold estimation or rapid screening is required. Threshold testing builds the hill of vision point by point. This is slow but precise. Supra-threshold tests answer only one question: is this point grossly abnormal or not? Modern algorithms trade minimal precision for massive time savings, critical for patient reliability. Examples are SITA Standard and SITA Fast. SITA stands for Swedish Interactive Thresholding Algorithm. Different test patterns sample different extents and densities of the visual field. Pattern choice must match pathology. For glaucoma, we use 24-2 or 30-2. For macular diseases, we use 10-2. For neuro-ophthalmology, we use 30-2 and peripheral fields. In reliability indices, we check for fixation losses, false positives, and false negatives. Never interpret a field before checking reliability. The sources of error are poor fixation by the patient, small pupil, media opacity, learning effect, and fatigue. Most field defects are artifacts. Always correlate with clinical findings. The analysis outputs are grayscale, total deviation, pattern deviation, and global indices. Grayscale can be misleading. Serious interpretation relies on deviation plots and indices. Mean deviation reflects overall loss. Pattern standard deviation highlights localized defects. Visual field index in the HFA is a measure of the patient's overall visual field function expressed as a percentage. The high sensitivity modalities are shortwave automated perimetry, which uses a blue stimulus on a yellow background, and frequency doubling test. These detect early glaucomatous damage but suffer from higher variability. Microperimetry maps retinal sensitivity directly onto fundus images and is especially useful in macular diseases, allowing precise structure-function correlation. Clinical correlation is non-negotiable in perimetry. Field is not equal to diagnosis. Always correlate with disc, OCT, and symptoms.